All right, it's my privilege to introduce Dr. Sandhya Panch for our grand rounds today. Dr. Panch received her medical degree from Bangalore Medical College and Research Institute in Bangalore, India. She then received her Master's of Public Health and Epidemiology and Biostatistics here at the University of Minnesota. She has other ties to the University of Minnesota as well. She then went on to do her residency in internal medicine at Georgetown University in Washington, D.C., followed that with a clinical fellowship in transfusion medicine and hematology oncology at the National Heart, Lung, and Blood Institute, NIH, Bethesda. She stayed on as a postdoc, as a research fellow in molecular hematopoiesis, and her mentor was Dr. Cynthia Dunbar. While she was there, she was also, within that mix of years, she was chief fellow in the hematology branch of the NHLBI. After graduation, I guess, she became an assistant research physician, which is the equivalent at the NIH of an assistant professor. And she was in the Department of Transfusion Medicine and the Center for Cellular Engineering at the NIH. And we know Dave Stronsek from there, and that's how I initially got to know Dr. Panch. Then from there, she went on to the University of Washington and the Fred Hutch Cancer Center in Seattle, Washington, and now as an associate professor of hematology at the University of Washington School of Medicine as director of transfusion at the Fred Hutch Cancer Center. She's committed to the pursuit of clinical and translational studies in the niche areas of hematology and transfusion medicine. Her research interests focus on evaluating auto and alloimmune causes of transfusion refractoriness. She's authored well over 70 peer-reviewed publications and book chapters, had many invited lectures and presentations in the areas of classical hematology and transfusion medicine. And as a practicing hematologist, she sees patients with a variety of conditions, including immune thrombocytopenia and immune hemolytic anemias. And at the University of Washington, as I think I mentioned, she attends on the inpatient hematology consult service and serves as an adjunct professor of pathology and lab medicine, covering the hospital transfusion service. And with that, I will turn it over to Dr. Panch. She'll be talking on furthering frontiers in platelet alloimmunization and autoimmunity, bedside to bench initiatives, and beyond. Dr. Panch.
Thank you. Thank you, Dr. McKenna. I really appreciate the opportunity to present here today, and I look forward to learning of any potential collaborative opportunities. Sorry, can everyone hear me okay? Yeah, yes. This is our land acknowledgement. These are my disclosures. So as Dr. McKenna mentioned, my research interests involve engineering blood cells for improved transfusion, transplantation, and immunotherapies, and I took somewhat of a differentiated career trajectory here. At the NIH, I had the opportunity to work on stem cell mobilization expansion studies, and thereafter I was involved in T-cell characterization at the Center for Cellular Engineering. In today's talk, I will try to summarize some platelet, allo, and autoimmunity data from my recent endeavors at the UW Fred Hutch. For the autoimmunity studies, I was fortunate to adapt omics-based approaches that Dr. Dave Stronsek at the NIH had developed that I learned from in the CAR-T immunotherapy world, and so I'm extremely grateful to him for his support. My objectives today will be to cover alloimmune platelet transfusion refractoriness, as well as a case of refractory ITP, provide some historical background in both cases, causes, mechanisms, diagnostics, as well as some ongoing projects in my group, followed by a discussion of the case itself. So platelet transfusion refractoriness due to HLA alloimmunization presents a significant medical problem, particularly among multiply transfused patients with heme malignancies and those undergoing hematopoietic stem cell transplants. This is a case here to begin with. This is a 35-year-old woman from Mexico with AML who receives leukoreduced apheresis platelets for a platelet count of 8 times 10 to the ninth. A 30-minute post-transfusion platelet count is still 9. There's no change after a second unit of apheresis platelets. Recent abdominal imaging shows mild splenomegaly. The patient has been pregnant 4 times and has received non-leukoreduced blood products in her home country. She demonstrates no signs or symptoms of bleeding, but an HLA antibody screen reveals a calculated panel reactive antibody, or CPRA, of 99%. So she's heavily alloimmunized. HLA typing is ordered, and quote-unquote HLA matched platelets are requested from the blood bank. So typically in these cases, once PTR, or a platelet transfusion refractoriness, or PTR as I will refer to it going forward, due to HLA antibodies is identified, the behind the scenes activities are largely a black box to most hematologists, let alone to patients. The output from the TSL or the donor center or HLA lab are periodic HLA matched transfusions, which I'm hoping to uncover a bit here today. So platelets as blood components and their adhesive properties were described by Bizzozero, an Italian pathologist in the late 1800s, as you can see here. Almost 70 years later, studies done at the NCI by Emil Frey and Freireich demonstrated a substantial reduction in fatal thrombocytopenic hemorrhage in leukemia patients following prophylactic platelet transfusions. The success of these clinical studies and technological advances in component separation and storage rendered platelet transfusions the life-saving therapy we recognize it today. Now, cases of platelet transfusion refractoriness emerged alongside the early use of platelet component therapy. Complement-fixing antiplatelet antibodies were identified in platelet transfusion refractory patients. And in 1969, Yankee and colleagues illustrated the importance of matching HLA antigens as a means to overcome HLA-mediated immune PTR. Now, measures such as universal pre-storage leukoreduction of transfused blood products have mitigated the risk of alloimmunization in the developed world. In the 21st century, there have been novel insights into the mechanisms of HLA alloimmunization and PTR, and newer platforms for antibody testing and potentially newer strategies to remove and downregulate platelet HLA antigens. And so there is a need now to revisit some mechanistic insights and diagnostics and management paradigms. And I will emphasize management strategies as well as studies that are ongoing at our center. So platelets express a variety of antigens on their surface as shown here. These include platelet-specific antigens, or human platelet antigens like glycoprotein 2B3A, 1B9, so forth. Ones that are shared with other cells like ABO or ABH as shown here. HLA class 1 antigens, typically A and B, rarely C antigens. And humoral alloimmunization due to HLA class 1 antigens represents the most common immunologic cause of platelet transfusion refractoriness. The table here shows a general proportion of PTR alloimmunization, which may or may not always result in platelet transfusion refractoriness, and immune and non-immune causes of PTR. Now, non-immune causes such as fever, infection, bleeding, medications account for approximately 80% of the cases, while immune-mediated causes comprise 20%. However, most cases of diagnosed immune PTR have concurrent non-immune factors at play. The slide here shows various definitions used to determine immune PTR. There's absolute count increment, corrected count increment, and percent platelet recovery. Now, platelet transfusion refractoriness is suspected typically when a corrected count increment measured within 10 minutes to an hour is less than 5,000 on 2 consecutive occasions. Now, of course, that can be debated and has been increasingly in the recent times. Some societies use a cutoff of 7,500 or 4,500 at 24 hours and so forth. One could also use absolute count increments of less than 10,000 as rough estimates of PTR. Percent platelet recovery of less than 30% at 1 hour post-transfusion has also been used. And once alloimmune PTR is confirmed and antibodies are identified, a CPRA or a calculated PRA is generated, and this represents the percentage of donors who possess HLA antigens to which the patient has made antibodies. And the transfusion service often calculates these values and helps clinical teams identify PTR and causes. So this illustration has many complex pieces here sewn together, broadly outlines HLA alloimmunization mechanisms in the bottom here, and platelet transfusion refractoriness causes on the top, and I will spend some time on this slide. The bottom half here shows HLA alloimmunization can occur via the direct pathway, the indirect pathway, or the semi-direct pathway. In the direct pathway, HLA antigens on donor-specific HLA antigens on donor antigen-presenting cells, such as lymphocytes or macrophages or dendritic cells, may interact with recipient T cells, followed by downstream T B cell activation and antibody production. Now, this is the major pathway of alloimmunization by non-leukoreduced cellular products, which is why leukoreduction is thought to be helpful. In the indirect pathway, recipient APCs may phagocytose donor platelets and activate T and B cell responses and alloimmune pathways despite leukodepletion. The third pathway occurs due to prolonged platelet storage and the consequent activation of apoptotic pathways may be stimulated, and fragments of plasma membrane from the donor's platelets may be incorporated into the surface of the recipient APCs, followed by allorecognition and donor-derived HLA molecules on recipient APCs. Now, following HLA alloimmunization, the circulating recipient HLA antibodies, predominantly IgG antibodies, may bind to transfused donor platelets with cognate antigens on their surface, and the antibody opsonized platelets are cleared via macrophage phagocytosis, as shown here. There's complement-mediated cellular cytotoxicity. There's also antibody-independent mechanisms, and theoretically, there's NK cell-dependent cellular cytotoxicity as well at play. And importantly, only a subset of individuals who develop HLA antibodies become transfusion refractory. And so when this occurs, both donor and recipient factors are thought to contribute to PTR. We'll get into some of that in the discussions of ongoing projects at our center. Diagnostics have also evolved significantly in the last decade. Since its inception in 1964, I don't show you that here, the serologic complement-dependent cytotoxicity, or the CDC assay, was the cornerstone technique for HLA typing and antibody detection. This test was resource and labor-intensive, and difficulties in detecting low-avidity antibodies and the inability to consistently tease out individual specificities in broadly reactive sera were problems. For HLA antibody testing, what is shown on top here on panel A, most laboratories have replaced the CDC assay with commercially available bead-based solid phase assays on the Luminex system. The illustration shows beads that are coated with one or more HLA antigens. Patient serum is added to the beads, followed by fluorescently labeled anti-human globulin to detect bound anti-HLA antibodies. Each bead is impregnated with a different ratio of dye, which then produces a unique fluorescent signature that can be identified by the Luminex technology. The mean fluorescence intensity, or the MFI, of the bound antibodies is the readout that is shown here in the red bars. Different types of readout depending on the strength of the antibodies can be determined. And this is a semi-quantitative method. For HLA typing, molecular methods or older molecular methods or newer molecular methods have supplanted traditional Sanger sequencing, as shown in panel B. Currently, platelet donors and recipients are typed for HLA class 1 at A and B loci at a lower resolution typically than is required for hematopoietic stem cell transplant HLA typing. Cross-match, platelet cross-match, shown on panel C, is a qualitative serologic assay to assess donor platelet compatibility with recipient plasma, where plasma from the allosensitized recipient is tested against multiple donor platelet samples prior to transfusion. And the assay is agnostic to antibody type. That is, it can identify anti-HLA, HPA, and or ABO. However, there are high false positive rates due to non-specific ligand binding. In severely alloimmunized individuals with high PRAs, donors may also need to be pre-screened and selected electronically for HLA and ABO types compatible with recipients in order to optimize cross-match success. These additional steps certainly limit the potential of platelet cross-match as a universal screening assay. HLA Matchmaker on panel D here is an algorithm that identifies the best matched units or best mismatched units using short amino acid sequences, epitopes, or three-dimensional eplets that are shared across HLA antigens of donors and recipients. And donor units with the fewest epitopic mismatches are considered more closely matched with the recipient. Some institutions also use CREG or cross-reactive group-based matching strategies to which recipients are statistically less likely to be alloimmunized. And institutions may use one or more of the above tests to diagnose HLA alloimmunization and to provide immunologically compatible platelet products to manage PTR. Now, irrespective of the methods used, the relative simplicity, availability, and declining cost of these newer assays underscores the need to relax gatekeeper criteria for HLA antibody testing, specifically the dogmatic need to fail at least 2 or more platelet transfusions, or the need for platelet transfusion recipients to earn an immunologic workup. This is my opinion, may need to be reconsidered in the presence of highly suggestive clinical history, PTR in the presence of multiple transfusions or prior pregnancies. I think are reasons why it may be important. It may be helpful to relax some of these criteria we've been using historically. So we've talked about pathophysiology of HLA alloimmunization and PTR. We've talked about diagnostic assays. And so how do you manage these patients? Strictly speaking, and I'll focus on the platelet transfusion piece for the sake of this talk today. Strictly speaking, HLA matched units are ones wherein the donor and recipient's HLA A and B antigens are either fully matched at all 4 loci or do not contain any mismatches. HLA selected units, on the other hand, and this is just nomenclature we use at our institution, and this can change across spaces as a way to distinguish between a perfect match versus something that is HLA selected. HLA selected units contain varying grades of antigen mismatches at 1, 2, or more loci, and typically transfusion physicians order HLA antibody results to identify antigen specificities to avoid, and this is called the ASP method. So it's not exactly allele for allele matched, but it avoids the antigens that the donor has formed antibodies or the recipient has formed antibodies against. You can further optimize HLA selected units either by epitope or CREG-based matching. One can also perform what is called permissive mismatching, wherein there is a donor-specific, or there are one or more donor-specific antibodies in the recipient. However, the cumulative MFIs based on the bead-based platform or other platforms that use some of these semi-quantitative techniques, one could evaluate the cumulative strengths of these antibodies and determine which antibodies need to be honored and which do not, which donor-specific antibodies do and do not need to be honored. And I'll talk about this based on some of the work we have done. Platelet cross-match compatible products may also be thought to be better than random donor platelets. I'll show you some data for that. Typically, when PRAs are less than 60%, while we're awaiting HLA testing and donor recruitment at some institutions, and certainly ABO compatible fresher units, there's fewer data, or there's less data for all of this. And of course, addressing non-immune causes is also helpful. So we've talked about HLA matched versus ASP versus epitope Craig permissive cross-matching, ABO compatibility, and so forth. So what is the optimal platelet component? And importantly, what are the outcomes that are impacted? So HLA matched platelets and ASP platelets began to be used interchangeably following this landmark study. Interestingly, it was a small retrospective study by Petz and Garrity in 2000, which demonstrated equivalence in terms of CCIs and the ability to widen donor pool when one used ASP platelets in addition to HLA matched platelets. A small study, but this was the big study in the area after the original Yankee study from the late 60s, which matched allele for allele as a way to increase CCIs. A 2013 systematic review of small non-randomized studies again showed a positive impact of HLA-compatible products on platelet count increments at 1 hour post-transfusion. Now, the studies were interestingly inadequately powered to detect changes in other outcomes, including count increments at 24 hours, bleeding rates, product utilization, and mortality. And so really, in most studies since, what has been able to be shown with HLA selected products is that there is improvement at 1 hour CCIs, but really none of the other parameters, including bleeding, product utilization, or mortality, have been able to be shown to help. Now, prophylactic HLA selection did not appear to reduce alloimmunization or PTR rates beyond what was offered by leukodepletion alone. And so we don't typically prophylactically match for certain HLA alleles. This is data from our single institution as a retrospective study with class 1. These are patients with class 1 PRAs of 60% or more. And we compared responses, CCIs, using corrected count increments, responses across random apheresis platelets and HLA selected platelets in patients with alloimmunization and PTR. Regardless of what methods that were used, HLA selected platelets included a combination of ASP, allele for allele matching, as well as Craig-based matching and permissive mismatching as well. You can see CCIs as high as 11.44 compared to 2.82 with just using random apheresis platelets. This is the process for identifying donors for recipients requiring HLA selected products. The report lists the patient's HLA type all the way on top here, and the HLA antigens to avoid, which correspond to the antibodies the recipient has formed in the next line, highlighted in the red box. Now, donors with any of these antigens are automatically eliminated by the computerized algorithm at the blood collection center. And then the rest of the donors are lined up based on the degree of compatibility, with highest compatibility or highest complete match to lower with one or more allelic mismatches. And so you can see the first patient here is at HLA 224646, and the patient's HLA type is also a 2246. So they are perfectly matched. However, other factors need to be considered there. Pre-donation count. Now, these donors may only donate every 7 days and up to 24 times a year. And so one has to factor that in, as well as when their last donation was, and their ability to be to come in for donations. And so we just go down this list. The match grades are different again across institutions. These are nomenclature for our match grades. Bottom line is we go down this list and call donors as we have specific patients with individual needs and continue to bring them in for platelet collections. So we reviewed HLA matched versus ASP selection with the Petz and Garrity paper. Now, what about epitope matching versus Craig-based matching? One randomized control trial partially addressed the question of the role of HLA matchmaker, comparing the performance of epitope-based refinement, or HEM, versus Craig-based refinement, or standard matching, which is HSM here. And both in the intention to treat analysis as well as in the per protocol analysis, you can see no differences in the CCIs at 1 hour. You can see 17.7 versus 17.5, similar numbers for the per protocol analysis. At 24 hours also, there was no differences in CCIs between epitope-based matching and HSM or Craig-based matching. However, what the study found was, this was a post hoc analysis, that there was a correlation between increasing eplet mismatches and 1 hour increment failures. And so the hypothesized benefit from HLA matchmaker was the identification of match products that may have been missed by Craig-based matching in highly alloimmunized patients. I also want to point to you that there were no differences in bleeding scores or any of the other outcomes that were evaluated. However, the strategy did not really, at this point at least, does not appear to have any measurable clinical benefits. So when and the UK and other places where donor inventory is more centralized, they do use the software. Now, there are free forms of the software that have also become available. Permissive mismatches, I'll talk about this here next. When no components are identified to which recipients are not already alloimmunized, certainly ones with PRAs of above 90% often encounter this problem, and one has to consider permissive mismatches. And what this is the presence, as I said earlier, of one or more donor-specific antibodies, but at lower cumulative antibody strengths. But the question with these components is, what is the optimal MFI threshold that one can use, a cumulative MFI threshold above which the product does not work and below which the product seems to work. So there were studies, small studies, that evaluated this question and used a cumulative DSA MFI cutoff of 6 to 10,000. And these numbers were largely borrowed from solid organ transplant DSAs. And interestingly, the numbers actually aligned quite well with solid organ transplant rejections, wherein with platelet transfusions, a cutoff of 6,000 to 10,000, anything less than 6 to 10,000, or I should say less than 6,000 typically, called low DSA platelet components, seem to behave like HLA matched units, whereas high DSA components above 10,000 typically behaved more like HLA mismatched units. And so we decided to look at this phenomenon systematically. And this was a study we just published, wherein we identified similar cutoffs. Actually, 10,000 seems to be that sweet spot of cumulative DSA MFI, as shown in the graph on graph A here, where HLA matched units, allele for allele, or well-matched units without any DSAs seem to produce a certain CCIs. We looked at less than 2-hour CCIs. And as you can see, at 1 to 1,000 DSA MFIs and 1,000 to 5,000, as well as 5,000 to 10,000, this CCI or the increment remains more or less the same. And then suddenly at greater than 10,000, there is a dramatic decrease to a point where they actually even look worse than random donor platelets. And this corresponded also, we looked at, we went back and did, on the same Luminex platform, we looked at complement activation. And this assay has been questioned. But interestingly, in our data, we identified that the ones who failed CCIs, the ones who had less than 7,500, we used a more stringent cutoff here at 2 hours, had significantly higher complement activation there in the red dots compared to the blues, who had, which were the CCIs that had passed or were above 7,500. And because this was a larger cohort, we were also able to ask questions about confounding due to splenomegaly, platelet storage solution, major or minor ABO mismatch, transfusion reactions, and so forth. As Dr. Ralph Vassallo at Vitalant refers to it, platelet CCIs are death by 1,000 cuts. And so even among the HLA alloimmunized, even though we dichotomize when we talk about the populations as being, immune versus non-immune, there's several factors involved simultaneously, especially in the heme malignancy transplant patients. You can see a significant impact of splenomegaly, significant worsening impact of splenomegaly here. Certainly platelet storage in past seemed to impact it some. We looked at about 18 different parameters and identified these 4 as the top reasons. Major, minor, bidirectional mismatch, not a significant effect size, but there certainly seems to be a decline overall. And these were the ones that were statistically significant. Transfusion reactions, because oftentimes the whole product is not infused, ends up negatively impacting CCIs as well. So once we had this information, we worked with the NIH folks who were also working on something similar to develop a computer-aided histocompatibility ranking, a simple R code that one of the fellows there had developed to rank basically platelet components from lowest DSA-MFI sums to the highest. And that way we were able to streamline and show donor selections in a way that improved CCIs over a 6-month period as a quality improvement initiative. So what about platelet cross-matching? There was this 2014 ICTMG review by Dr. Vassallo and others that confirmed its utility in increasing CCIs in alloimmune PTR patients compared to unselected platelets, but it did report equal or worse performance against HLA-matched units. Now, several recent studies have also shown this in resource-limited settings where platelet cross-matching has been successful. Overall, again, they looked at other than the 1-hour CCIs, none of the other outcomes were impacted. ABO compatible fresher platelets, there is data for the use of ABO units from retrospective studies. Appears that minor ABO incompatible components may be in general better than major ABO. Now, one study showed no effect of ABO, and the other 3 showed that minor may be better than major or bidirectional ABO incompatibility. So what about testing for PRAs? How often should we be testing for PRAs just like we do for red cell antibody screens? Because these, the TRAP study from the 90s showed that HLA antibodies actually wane over time. And because it was a prospective study, they were able to demonstrate, this was of course using the CDC assay, but they were able to show that more than 50% of antibodies waned over a period of 14 to 20 weeks or so. The median was about 14 weeks. And Lee and others around the same time, or actually it was probably in the early 2000s when they demonstrated that not only did the antibodies wane, you could also re-challenge these patients with random donor platelets, and they did fine, unlike with red cells. Especially hematopoietic stem cell recipients who were also immunosuppressed, one could definitely envision doing this and widening the donor pool. There was one stem cell transplant study that looked at PRAs a little too frequently, every 4 weeks, and they didn't show any difference between, if you did it that frequently. And so we think that the optimal retest interval should be about 8 to 12 weeks. So if the antibodies wane, because at this time, most institutions, and correct me if I'm wrong, but most institutions evaluate PRAs once and then in the beginning. And then if there is a suspicion for, worsening refractoriness or some other specific reason, and not really preemptively every 8 to 12 weeks as a way to widen donor pool and re-challenge with random donor platelets. So we are making a push to do them sort of preemptively. And this was also shown in our population, where allogeneic stem cell transplant recipients showed a greater decline, likely due to ongoing immunosuppression, and a lot of them could be re-challenged with a wider donor platelets from a wider donor pool. So overall, the conclusions for this part of the talk were that HLA matched units are similar to ASP, which are definitely better than cross-match, it appears. And cross-matched units are still, platelet components are still better than ABO or fresh components. And these may be better than random donor platelets. ASP plus Craig matching at this point appears to be equivalent to ASP plus epitope matching. And antibody-guided low MFI mismatches may be equivalent to HLA matched / ASP units. And the retest interval for PRAs is about every 2 to 3 months to widen the donor pool, appears to be. So we wanted to go a step further. This is data from a recent study that we have been working on, and ask the question of whether, like with red cell antibodies, are there specific HLA antibodies that are enriched or depleted in a group of patients with either platelet transfusion refractoriness or those with alloimmunization but no refractoriness? Because that's the big question. And so one of our excellent residents, who's now a fellow in the Hemonc division, also a math whiz, evaluated this prospectively in a cohort of leukemia and stem cell transplant recipients. Now, these are patients with leukemia who come in through the door, never been transfused sometimes, and receive HLA antibody screens prospectively at baseline and over time, as well as HLA typing at baseline. And so we have data, and the data looks sort of like a reverse J, if you will. Most people have 0 PRAs, and then there's some who, there's not too many in the middle, and then there are some who have 80 to 100 plus PRAs. So that's the division, that's the pattern that we overall observed in these patients. And interestingly, as shown in the waterfall plot here, HLA B45, B8, certain antigens like B45, B8, B44 were associated or were depleted in the PTR group, which means that even though they were alloimmunized and quote-unquote platelet transfusion refractory, if you challenge these patients with B45, B8, or B44, they still seem to respond appropriately. And this has been shown in prior studies where donor expression of B8 or B44 may not be uniform. A third of donors are thought to have very low expression of these antigens, and therefore, even if there is a donor-specific antibody against some of these antigens, one can still, the CCI, the corrected count increment still is pretty good, okay? But we didn't get too much further there because it just got extremely complicated, because as we all know, antibodies recognize epitopes rather than entire antigens. And so epitopes can be structurally defined as eplets and small regions of these, as shown here in the 3D structure. And many HLA molecules share specific eplets, and a single anti-eplet antibody can recognize multiple HLA antigens. And that is what ended up happening. So we are working with our informatics team currently to tease apart some of these, but we just don't have the numbers. One needs significantly higher numbers to be able to ask the question of whether certain pools or groups of antibodies are enriched or depleted in alloimmunization as well as PTR versus non-PTR patients. So beyond these strategies, there's limited evidence concerning the management of PTR in severely alloimmunized recipients with PTR as with recipients with DSA in solid organ or hematopoietic stem cell transplants. Drugs that target various mechanistic pathways have been attempted, and these include IVIG or plasma exchange, rituximab, and other B-cell directed therapies, as well as eculizumab. Recently, imlifidase, an IgG cleaving enzyme, was shown to neutralize Fc receptor function in solid organ, has demonstrated successful and consistent CCI increments in a case report or case series. Preclinical studies have also used acid-treated platelets, HLA antigen Fc fusion proteins to deplete B cells. There's allogeneic universal donor platelets, which do not express HLA class 1 antigens because of beta-2 microglobulin knockouts on their surface. And so these are all possibilities in the future, I would say. We are also in the process of developing a vein-to-vein registry repository study to ask and answer some of these questions. With regard to management itself, in addition to some of those platelet optimization studies I showed you, we have been in conversation with a company that makes a drug called efgartigimod, which has shown benefit in chronic ITP. And it's a neonatal Fc receptor antagonist and has been used to deplete IgG or other antibodies specifically. And the thought is that maybe if used pre or peri-transplant or just around the time of consolidation, that one could get transient antibody depletion and potentially help mitigate alloimmunization and open up the donor pool wider for better transfusion responsiveness. And so that's one drug that is in the offing now. There is increased risk of CMV EBV reactivation, so that's also something to consider as we move forward with some of these therapies. So coming back to our case here, the initial transfusions before we actually had an HLA type and antibody screen on her, you can see over the first 5 days in these green circles, she didn't really have a response. And then over time, even though the line is pretty jagged here, you can see the general trajectory is upward, which means that her CCIs, which are shown on the x-axis here, continue to increase over time. And eventually she had a post-stem cell transplant. She had count recovery and transfusion independence, thankfully. This was the lady with the extremely high PRA. So she was a difficult one to match. And we had to move heaven and earth to find donors. Thankfully, our donor inventory is large enough that we are able to support most, if not all, of these alloimmunized patients with just internal inventory alone. Her PRA also declined over time, as you can see here, and we were able to widen her donor pool. So that graph I showed you previously was despite widening the donor pool, suggesting that you don't mount a response against antibodies that have waned over time. So that's my summary of HLA alloimmunization or alloimmune platelet transfusion refractoriness. I will give you a quick 10-minute summary of the autoimmune platelet destruction that happens in ITP. This is a 42-year-old female with ITP, was diagnosed a year ago. She had very low counts. She initially responds to steroids. And now she reports intermittent epistaxis. Her counts are low. She's tried several different therapies. She's managed on maximum doses of a TPO-RA, thrombopoietin receptor agonist called L-Thrombopeg, and low-dose steroids, and the patient does not want a splenectomy. And so what are her management options? Do we initiate a second TPO-RA, redose rituximab, increase the dose of steroids, refer her for a clinical trial, or observe? Now, I did talk about alloimmune or HLA, and so now this is a brief focus on platelet-specific markers or autoantibodies against these platelet-specific antigens. So ITP is an autoimmune disease. It's characterized by decreased circulating platelets and variable bleeding and decreased health-related quality of life. In the 50s, the pathogenesis of ITP was thought to be mostly autoantibody mediated, for which all patients received steroids, IVIG, and eventually a splenectomy. In the recent years, studies have helped elucidate a number of features as shown here. There is the role of complement, there's macrophage-mediated phagocytosis, T cells, B cells and antibodies, FCR and antibody recycling, so on and so forth, and as well as T cells. And so, all these boxes that I show you here are either drugs already approved, the black ones here, the 3 TPO-RAs and fostamatinib are US FDA approved, and rituximab, of course, has been used for a long time as a splenectomies. But everything else here in the blue lettering are all drugs that are in clinical trial. In fact, we joke that there are more clinical trials than there are patients in this space right now. So the lack of universal predictive biomarkers is a huge problem, whether it's for risk stratification of disease or response to treatments. And this represents a major unmet need in ITP. And so even more important today, because as I showed you, the growing number of therapeutics available to improve patient management there. And so with the aim of personalized medicine, that is to offer best treatment to a patient at any moment, it's important for us to leverage tools that are available right now, including some of the DNA, RNA, proteomic approaches, which the heme malignancy world, CAR-Ts and other spaces have already begun to explore quite keenly there. And so right now, what happens in ITP management is we just keep throwing different therapies at these patients sequentially and enroll them in trial after trial after trial if they have failed, the standard agents. And so the real question is, how do we, in these refractory patients, how do we risk stratify them and identify biomarkers to see what they would, to predict and preempt responses versus non-response in these patients. And these studies have evaluated in the past various cytokines, cellular subsets, and gene polymorphisms. Platelet desylation has been evaluated, which occurs predominantly in the liver, in the context of glucocorticoid response, and so forth. Recent studies have more systematically evaluated this question. This is thrombopoietin receptor agonists based on TPO levels. This was a ROC analysis that demonstrated that TPO levels under 200, depending on which thrombopoietin receptor agonist you use, was helpful in discriminating responders from non-responders. Basically, if you had higher levels of TPO, the chance that you would respond was lower. However, the study showed that even among these non-responders with high TPO levels, if you added some steroids, low-dose prednisone or other steroids, you were able to stabilize their response or even increment their response appropriately. But TPO can be used, for instance, to distinguish responders, non-responders. Splenic sequestration, this was a recent study done in Spain with their transfusion group that demonstrated, again, using indium-labeled scintigraphy, that spleen sequestrers overall had better responses, as is logical, after splenectomy compared to hepatic sequestrers. And the absence of splenic sequestration, which presumably the destruction of these platelets happened in the liver, was associated with a 3-fold greater relapse risk after splenectomy, which is what is shown in the Kaplan-Meier curve on the right there as well. Splenic versus non-splenic sequestrers, relapse-free survival was significantly higher in the splenic sequestrers. Interestingly, this study was done at the Puget Sound Blood Center and Fred Hutch in the 80s with Dr. Cheryl Slichter and others, where they looked at survival times of radio-labeled autologous platelets in the blood bank in these patients with ITP, and again demonstrated hepatic uptake was associated with worse response or relapse after splenectomy. Daratumumab is an anti-CD38 antibody developed for multiple myeloma, has increasingly been used in autoimmune cytopenias. And again, this small study demonstrated T-cell CD38 expression was helpful in distinguishing responders versus non-responders. I won't get into the details here. We, in the context of using daratumumab, this was helped with Dave Stronchik again, evaluated a patient who was post-transplant, 8 months in remission, and developed refractory ITP with bleeding after COVID vaccine, as shown here in mid-2023. We threw everything at her, as you can see here in the red lettering. Nothing worked. We gave a single dose of daratumumab, which showed a slight blip, and then decided to continue daratumumab for about 6 doses. We collected data for cytokines and transcriptomics before and after, and demonstrated significant decline in inflammatory markers, including JAK-STAT, MAP kinase signaling, mTOR signaling, and so forth. This is all very preliminary data, but we also looked at certain cytokine factors as potential predictive biomarkers. But I think this is where the field should head overall. This was, again, a continuation of the same study. We sequenced and performed transcriptomics and cytokine assays and single cell sequencing on and nobody has really done this systematically, looking at ITP almost like a wastebasket umbrella of all kinds of cases. Nobody has really risk stratified these patients as we have data for in lymphoma and other hematologic malignancies anyway. So this is a sort of a first step in that direction. We've also used the same approach to study the effect of fostamatinib, which is a Syk inhibitor, and reduces macrophage-mediated platelet destruction in chronic ITP. Again, with transcriptomics and cytokine analysis that were developed in the CAR-T space, we were able to demonstrate differences in, for instance, in macrophage migration inhibitory factor among responders and non-responders, potentially using some of these as methods to distinguish these populations and maybe even identify differences at baseline. Leniolisib, abatacept, these are also, as I mentioned, these are all the slew of new agents that are being developed for ITP management. But really the question we should be asking is, who's doing the correlative studies, and how can we both risk stratify patients and develop biomarkers as we progress through these sequential therapies. So overall, I think I've shown you some data on TPO levels, splenic sequestration, T cell CD38 expression. There's phagocytosis pathway, MIF levels for fostamatinib, PIK3 kinase inhibitors, mTOR inhibitors have all been used. And again, one does need to perform systematic studies to identify biomarkers for these spaces. And so we are in the process of developing an autoimmune cytopenia registry repository to ask some of these questions. And so coming back to this case of refractory ITP, the answer is to obviously refer her for a clinical trial, but I think it also behooves us to ask questions about disease mechanisms, drug efficacy, toxicity, using mixed-based approaches, and as a way to personalize medicine. So I hope I have taken you through this whirlwind tour of alloimmune and autoimmune platelet transfusion refractoriness. I thank my large group here for their support, and I'm happy to take any questions.
Thanks, Dr. Panch. That was a great talk. Are there any questions?
Yes. Hey,
Claudia.
hey, Dave and Sandhya, fantastic talk. I really respect the work that you've been doing. I have 2 questions. The first is about your cumulative MFI work. If an antibody specificity is less than, say, 1,000 or 2,000, whatever your cutoff is at the Hutch to call an antibody an positive, is it included in the cumulative MFI?
Yes. So I can take you back to where and so we use, on the study, I think before we did the study, we used a cutoff of 2,000 or something, 2,500 maybe, if I'm not mistaken. And so anything over 2,500 was added towards the DSA MFI threshold. But so you're asking if they were under 1,000, did you still measure it?
Or under 2,500?
Under
Whatever you cut off.
2,500. So yeah, so we went back and yes, so we did, because if you had four antibodies that were exactly against all four, the donor had antigens against all four DSA alleles, right? That would matter. And so we did go back and calculate all of those. And of course, if they were less, we had to include those populations because we figured it would help increase our individual quantification power as well. And so we did go back and look at all of the all the way from zero, basically.
Okay, great. Thank you. Second question is about the 8 to 12 week period between serum testing. If you saw that a patient's antibody had waned and was no longer positive, and you selected that platelet donor, did you see an amnestic response in the next serum, or is the timing so wide that it didn't matter?
Yeah. Most of these patients were on immunosuppression, Claudia, and so I wonder how much of a role that played in making sure that the antibodies didn't reappear. Studies by John Semple from the 90s showed that a lot of these patients actually may develop anti-idiotype antibodies and therefore did not mount a response over time after the antibody after the antibody strengths decreased or their appearance changed over time or declined over time. But we weren't able to systematically look at that question. That's an interesting question. We didn't, of course, we checked every 3 months, which itself cost a lot, and we had to put up a big fight to change.
Well, thanks so much.
I think Penn has a question.
Oh, yes. Thank you, Dr. Panch, for that great presentation. I think first of all, I'm one of the directors in the HLA lab here at the University of Minnesota. My question goes to, I think it's probably slide 33, where you mentioned that there were patients that have never been transfused and demonstrated when they had the B44-45, they apparently depleted faster in the PTR group. And so, but the thing is that those particular antigens are associated with false positive reactivity. So the question is, what did the group do to kind of assess those reactivities?
Yeah, no, that's a great question. So I know this was a sort of a convoluted way of looking at the data, but we tried different ways to present it. I think we were grappling between, well, should we show what percentage of patients had increments? And that didn't seem to pan out with the various antibodies that we were looking at. And so the best method ended up being, well, how often is there enrichment in platelet transfusion refractory cases when they have one or more of these antibodies, right? And so what we found was that the PTR cases were depleted, which means that there were fewer PTR cases and we looked at this at the transfusion level as well as at individual patient levels. If the recipients had B8, B44 antibodies, or the donors had these antigens, they were less likely to form, they were less likely to have lower CCIs. We have just like you, Penn, there is our counterpart, Danny Youngs, who very methodically eliminated cases where he thought there was potential for antibody cross-reactivity. And the data were collected at 3 different institutions. So he systematically screened for some of those cases. And then went back and also looked at donors to see if their prior transfusions had resulted in increments in ways that some of these hadn't. to again question whether it was specifically related to those particular antigens. And as you know, there is data in the literature suggesting that B8, B44. Now, as you see, I mean, this wasn't done systematically. I just showed you some examples. We don't know why A32, B62 are so depleted, but then A32, B62 were also in other epitopes that caused enrichment. So the bottom line, that's why we haven't published
Recording
it yet,
stopped.
I feel like this just too much confounding in the data.
Yeah, certainly. And then the second question I had is, was there any time when they looked at the impact of potential passenger donor HLA antibodies on the outcomes of matched platelet transfusions?
No, we haven't looked at that. And that would be something to discuss, I guess, with your team.
Thank you.
Thanks, Sandhya. I have a question, but I think we're at time, so I might just email it to you. Any other quick questions? I think it is at 9, and I think we have a faculty meeting right after this as well. So, Sandhya, thanks so much for the excellent talk. It was great to see you. Reach out to Dr. Panch if people have ideas maybe for potential collaborations. I think that would be a great thing. And I will email you in a bit here, Sandhya, with my question.
Thank you. Appreciate
All
it.
right. Take care.
Thanks.